Well, we're going to go ahead and begin. I think we'll have some more straggling in. Yeah, I think we'll have some more straggling in. And I want you to know how much it means to us to have you here. Even though our numbers are small, this is such a vital thing for us to stay connected as alumni, to encourage each other, and also to share the important work that we're doing. And so I want to welcome everybody here and thank you for coming. Thank you for being at Rover Teams today. The nice side of the small number is that we have a chance to really get to talk to each other and meet. And so that's just wonderful. So we appreciate you being here today. If you didn't pick up, if you didn't sign in, there is a save the date card. If you are an active student or an alum, we want to make sure that you get that on your calendar, because we want to have a totally rocking alumni event in February. Friends are allowed to come too, not just alumni. Yes, yeah, please do come. Please
come with me, Jamie.
Jamie. And we do have an alumni meeting following. We know that everybody gets to, but you're welcome to your meeting. That's right. That's right. So with that, I'm going to get formal and I'm going to introduce. It's just my absolute pleasure today to introduce Dr. Marguerite Fallon. And Dr. Fallon, yeah, go ahead and clap for her. Marguerite is she's our first LCU grad to complete the DNP, which was done in 2011 at Texas Tech University. We're so proud of her. And actually, our topic today was her capstone project. So the topic that we are going to be privileged to hear about today is the culminating work of her DNP program, and others are going in that direction, and we look forward to your, that's right. We look forward to what happens in the future there too. But I'm especially proud to say not only did Dr. Fallon graduate from Texas Tech, but she's an alum of Lubbock Christian. She was in our inaugural class, so she graduated with her master's in 2007. There's several others, and we're so glad to have you here today. We're so glad to have you.
Sorry, y'all.
I don't blame you for celebrating that.
No, we're so proud. So that was a lot of blood, sweat, and tears to get that program there and to have that first class go through. So we're so proud. And then in 2005, our BSN program. Oh, and let me say, by the way, if there's anybody here that doesn't know Dr. Bev Myers, our graduate director over there, we're glad to have her. But let me tell you a little bit about Marguerite. First of all, it would take the remainder of the time for me to tell you all the wonderful things about this fabulous person. She's an outstanding leader. She actually started, she's had many lives, but in her nursing life, she was a clinical educator at Covenant, and recognizing the gift she had to move that unit forward, she became the nurse manager, was in the nurse management role for about 3 years, and then actually moved to the current position that she has, where she is the director of operations of all women's and children's services at Covenant. And that includes labor and delivery, mother, baby, antepartum, NICU, PEDS, PICU, and ECMO. And we have observed as faculty, of course, we're like proud mother hens of our graduates, aren't we, Dr. Bev? We just feel like we've invested a little bit of ourselves, and it's our absolute privilege to be able to say that. But when we have graduates that go out and really take to heart their practice and change practice and make life better, not only for the people they work with, but for the patients, then we just praise God for that. And so, Marguerite, we're so glad you're here. Thanks for sharing that, and let us hear about your project.
Thank you. That was quite an introduction, Dr. Long. I don't feel like I live up to all that. Can you hear me? Was I supposed to turn this on or something? Okay, good. All right. I'm really bad with technology. And I have to tell you, I had Invisalign braces put on yesterday, and so if my enunciation is poor and I lisp, it is because of that. I'm trying really hard here, really hard. This is well, I'll just use this. All right. My project was based on my love of making sure children in the hospital survived a discharge, because I had witnessed, several opportunities within the hospital that perhaps maybe the child could have done better if something had been done earlier. The same premise for rapid response teams and how important they are in a hospital. I had been looking for a project to do during my DNP, And I found an article, and sometimes just finding one article really sets the trajectory for what you're going to do further down the line. And I found this article of a Rover team that they had at Duke Children's Hospital, and that led me to my passion. And I connected with the author of a paper. She's a pediatric critical care nurse practitioner and a colleague of mine now and a friend. And she kind of helped me through this. And I really owe it to her. So we know that rapid response teams are important. We heard about that years ago, 100,000 Lives campaign, you know, the needless deaths in our hospitals, which is, you know, a shame. It is a terrible shame. And how can we work on processes to save lives? People who come for care and treatment and expect to live and be saved in a hospital who aren't. So that's the compelling call that I had. Rapid response teams are great, and they do save lives, but they have limitations. They respond when a call is made, and so they respond quickly, and they assess a patient, and they do something. But what if we could recognize a patient earlier and make a difference? So that's what this is about. So the rapid response team also, it relies on a nurse recognizing that there's something wrong with the patient and having the knowledge and expertise, the years of work, the education, and the workload to recognize that. If you have 5 or 6 patients, sometimes, you know, it's easy to overlook changes in a patient's status. So the nurse's role is extremely important. And then there's literature out there that supports this one key piece that says any arrest that occurs outside of an ICU is potentially avoidable. And I believe that, because everybody presents with some signs and symptoms, and if we catch those early enough, we've saved somebody's life. So children are the same as adults. Their subtle signs are usually available to see for everyone who wants to know 6 to 8 hours before. But it's picking up on that and cluing in on that that's important. With children, survival to discharge after you've had a cardiopulmonary arrest in the hospital is only 16%. So it's bad. So we want to do something about that. So what I wanted to do was start a Rover Team. What a great name for a pediatric hospital, Rover Team. You may have heard of critical care outreach teams, surveillance teams, proactive rounding. All of that would be the same. But who here uses those in their hospital now? Yeah, no, we don't. So anyway, we took this concept and decided, hey, this might really be important if we identify patients just by looking for them instead of waiting for that call. What if we actually went and looked for them and asked people, is there anybody you're, kind of concerned about? So that is the focus of this project. The setting is Covenant Children's Hospital, my hospital where I work. Not-for-profit licensed children's hospital. We serve a 64-county area. We have a 38-bed level 3C NICU, 14 ED beds, and depending on how many beds we've taken away for offices and, family resource centers, 35 beds right now, 20-bed PICU. We're our level 2 trauma center, and we do have ECMO services. Our ED visits for the children's hospital alone are over 25,000. And we have about 3,000 discharges annually from the pediatric floor. So who is the Rover nurse? That blonde-headed girl is the Rover nurse that day. Megan went through this program also. The Rover nurse is the PICU charge nurse. She has her duties in the PDICU. She's busy, but she takes time once per shift to go up to the pediatric floor, the med-surg floor, talk to the charge nurse there, and say, hey, are there any patients you're worried about today? Do you have any questions? Is there something that you're worried about that I can help you with? So that's the premise for that. So they discuss any at-risk patients. She may lay her hands on the patient. She may go into the room and look at the patient, assess them, reposition, suction, and take the TPCN nurse in there with her and help educate. So a lot of this we find is just, you know, a lack of skill, because a lot of our nurses on the pediatric floor, you know, have not been nurses a long time. So they don't have the same skill set sometimes that the ICU nurse does. So it's great. It creates synergy. It's a wonderful thing. In the beginning, it was a little difficult because the floor nurses thought that they were being scrutinized, that maybe they did not know, you know. So it's been a culture change, and we've developed a great synergy with the floor and a great team. So if the Rover nurse says, you know, this patient looks kind of bad, you know, let's go ahead and get them transferred to the ICU. So that's what that nurse would do. And we have a policy supporting that also. So we'll go on, and you know, one thing I didn't mention, those patients that are most suspect are patients that have trachs, chest tubes, EVDs, respiratory problems of any kind, or have transferred from the PICU within the last 12 hours. Because a lot of times you get readmits to the PICU, the bounce backs, because you haven't noticed something. So it's just a picture of our Rover team in action. I already told you, you know, that we look at a Rover team as proactive rounding or critical care outreach. That's what you can find in the literature. There is literature out there for this in adults, but again, not in children. So we started this pilot project in January of 2010. We developed a tool, and I can't get my Rover Team tracking tool to open, but if anyone wants to see it, I'd be glad to share it with you later. It's a piece of paper that we fill out and identify a patient if they're at risk. It looks at vital signs, it looks at, you know, respiratory rate, if there's any issues of any kind, and that's how we collect the data for that. All right, so my project was a retrospective chart review, and it was 49 patients that I looked at to gather some information on these rounds and see how effective they were at my hospital. And you always have to have a few questions when you do this. You can't just go in and already know what's happening. So the questions were kind of vague at first, and then as I got into my project, they became a little clearer of what I really wanted to do. There's only so much time you have in a little over a year to do something like this, you'll find. So those are the questions. What are the assessment findings and interventions on these patients prior to admission to the PICU? So I had to go through the charts and look at them. Had to look at what the nurse documented as far as vital signs and interventions, like did you have to suction the patient? Did you increase the oxygen delivery? You know, did you have to call the physician? Those types of things. Those are the interventions that I was looking at. So what happened with these patients that went to the PICU? What was the mortality and morbidity after they were admitted? Well, then they always want you to have a theory. You know, that's always good. You utilize those theories, and they actually make some sense. I used Rogers' diffusion of innovations theory, and it talked about how you communicate these ideas among staff and make them understand and perhaps garner some buy-in with your project, because you always have to have that buy-in or your project's not too successful and your data is kind of meaningless. So it seemed to fit this project quite well. So adapting a new team, this Rover team, and moving it into the pediatric floor fit perfectly with this theory. Again, I looked at charts on these patients cared for in the PICU that were transferred from the general inpatient unit for a 6-month period of time. I had a data collection tool that I devised myself. Again, I can't open these. I think you actually have to have the document saved on your flash drive for it to open. So I'm sorry about that. But if you want to see it, sometime you can. So there were 17 pre- and post-transfer assessment findings and interventions that I looked at on each patient. And I looked at this, evaluated it for data groups, counts, frequencies, commonalities, what was common in this big group of patients, and looked at that. So some of the things I did, I looked at vital signs. Were they within normal limits at 4, 8 hours pre-transfer? What happened? Like I said before, was the oxygen applied? Was there another IV started? Were there more medications ordered? All those were considered interventions. And was there increased or decreased morbidity across these groups that I had? And how many of these patients, once they were moved down to the PICU, actually required advanced airway management and intubation? And then how long did they stay in the PICU after we recognized them? So we put the data into SPSS and examined it using descriptive statistics. So what did we find? 452 admissions to the PICU during that time frame. We had over 1,600 admissions to the pediatric floor. 49 of these charts met the criteria for the review. We had 11 transfers from our Rover team, 6 transfers from the rapid response team, and 32 transfers from physicians. So they had to be, the patients' ages were anywhere from newborn to 18 years of age. That's our patient population there. If the patient was an expected transfer to the PICU because they went to the OR, and that's what we usually do, I did not look at those charts because that's the normal course, so I excluded them. So it was only those 3 groups of patients that I looked at. And that gives you, I put this on a different background, but that red column is the age group of the patients that were transferred. They were little babies, most of them, 0 to 3 months. And most of those are respiratory issues. So age group of patients transferred may be an important part of developing early warning systems and activations in the future with the EMR. So the highest number of transfers were during January through April, of course, because that's RSV season and that's when little kids get the sickest and they have their respiratory problems. 33% bronchiolitis, asthma 21%, pneumonia 12%, sepsis 8%. But that's normal to find those types of things during that time of year. There were other diagnoses that we looked at, some cardiac, 1 meningitis, a shunt malfunction or 2. So we expected to use oxygen when they went to the ICU. That's the most used intervention on all of these folks, all these kids, because they're kids and it's respiratory season and they have RSV, so high flow oxygen via nasal cannula was what we saw as the major intervention. And I expected to find numerous calls to physicians by the pediatric med-surg nurses documented in the nurses' notes because we had all of those transfers down by the physicians. But one thing I found doing this was the documentation was really poor. It was hard to find those things. That's, you know, you're not really looking for that, but then when you find it, you're like, oh my goodness, what's going on here? So that was one thing. Found a lot of things, but that was kind of interesting. So that's just a little diagram of the interactions and how they were grouped together. It wasn't very significant. The control was the physician group, the physician transfers, those 33 transfers. The intervention group was the Rover Team, and then the rapid response team on the right. And that just is looking at how many interactions each group had, those ones that were transferred to the PICU. So then this is pretty representative of what you would find, you know, with any rapid response team, review of charts, and what the vital signs looked like. But they were coded in my data collection sheet as yes is normal or no abnormal. And it was based on what is normal by PALS, what our PALS manual guides us as what is normal. So I used that. And I did not distinguish whether the child's oxygen sats were on oxygen or on room air. This would need to be done in the future. That's something that I didn't do and I missed, and I probably should have done that. So 61% of pediatric cardiac arrests were caused by respiratory failure and 29% due to shock. Both are, you know, if they're caught early, are reversible, right? So that's the interesting thing to me. The Rover team was successful in intervening with all cases transferred to the higher level of care before cardiac or respiratory arrest. So, yay, that worked. So that gives you an idea of how many, you know, the respiratory rate. All of them had abnormal respiratory rates prior to transfer at 4 hours. I had trouble finding documentation for capillary refill, though. That was kind of sparse in the documentation. Lots of missing values, which made it very difficult to look at this. So this I find very interesting. 11 of the patients transferred to the PICU by our physician staff had a length of stay of 1 day. So you tell me if you can figure out why. And these were patients transferred in the evening. Night transfers after 10 p.m. totaled 49% of these reviewed. So they didn't want to come in. They thought, well, I don't want to be getting calls about this patient all night. We're just going to send them to the ICU. And then the next day, you know, someone would see him and they'd go back upstairs. Well, how is that with cost and utilization of an ICU? You know, so it was rather shocking. All right. So that's pretty important to me. Those patients requiring intubation within 4 hours of transfer to the PICU. The Rover team, spot on. They were good. Rapid response, none of those were intubated. And there was one physician that his patient was intubated. So basically the Rover nurse intervened before a rapid response call was made, potentially avoiding that arrest and perhaps increased morbidity and mortality on the floor. So why would we not want to do that? It just makes total sense to me. So the total number of interventions applied to the patient were less than the Rover team transfers. How interesting is that? So that suggests that maybe that's a lower cost way of delivering care. You would think not. You would think the opposite. But further investigation is warranted. The Rover nurse length of stay for patients transferred was greater than 1 day, and all of them. None of those were just bad cases of judgment. They all stayed more than 1 day. They were sick. They needed to go down there. So it may be a less costly practice, and that's something that, you know, hospitals want to look at. You know, the bearing the cost of, you know, a clinical critical care outreach team or, you know, proactive assessment really does cut your costs, because you know the cost of an ICU stay, and you know the cost of intubating a patient, or, you know, all those things. If these things can be picked up earlier by, you know, really good clinicians, then we cut some of that cost, and, you know, the mortality is lessened. So we revised the tracking tool after the pilot study, and that was done because some of the questions on there were kind of really not needed, didn't give us any information that we really needed. Okay, 3 of the 11 patients transferred by the Rover nurse were critically ill and required immediate airway intervention, intubation for respiratory failure. And the big thing is we had no deaths during that time period. We actually had no deaths or arrests on the floor for a year. That's astounding. That's astounding. So my findings included that having the proactive assessment, having the Rover Team nurse go to the general pediatric floor may affect all of our patient outcomes and subsequent morbidity and, again, mortality. I feel like it did. And then, of course, with the current increased emphasis on patient safety, it would be beneficial for all of our leadership and all of our hospitals in the region to consider the implementation of this type of proactive roving, proactive critical care outreach to be an adjunct to your rapid response teams. And I didn't even talk about, you know, how much time is spent by that PICU charge nurse on the floor, and Rachel could probably tell you this, it's not much time. You know, in the off season, 15 minutes perhaps. When it's busy in RSV season, you know, they may spend 30 minutes up there. They may have to go into several rooms. And, you know, it takes her away from her unit, but there's always someone in charge that can, you know, hold the fort down while she's up there. But that's a minimal cost. It's almost cost negative. So,
Because you're already paying them to be there.
Exactly. You didn't have, you didn't have to hire another FTE to do it. And obviously it's, you know, a very negligible investment to have great, you know, great outcomes on the pediatric floor or the children's hospital for all of them. Okay, so it can be suggested that this Rover team is a more efficient way of dealing with this, you know, than a rapid response team. It's more efficient. You don't have to rely upon someone recognizing that someone is not doing well. Again, busy nurses, it's terribly busy, patient loads are huge. You know, you don't have to rely upon that inexperienced nurse making that call. You know, you are relying on the clinicians that have been doing this a while and are experts in, you know, deteriorating children. So the use of an added consultation like this for nursing is highly desirable, strengthens the team dynamic and communication, and that's a big thing. I think, you know, having that nurse come up and they get to know each other and, hey, that we're here to help, you know, it puts a different spin on it. You know, the communication is much better, I feel, between the units now. So the synergistic effect of this team enhances patient safety and is a better practice model than just a rapid response team alone, in my opinion. And then I have, you know, ideas, and Jamie's going to help with all of this because she's so smart. But, you know, really look at, you know, generate a high alert list for other people even. So when we know that there's these vital signs that are not within normal parameters on the EMR, which we do not have yet, which we will have someday, yes, you know, then there'll be other people involved in this, because if you have more people, you know, involved, it's a greater chance of someone catching something. So they're doing this in other places with their Muse and Pews, so we want to jump on that too one of these days. So that's why I put that in there. And then I just have my acknowledgments of my friends and then references. And I know that was short, and this is really the reason why we want to do this. It's because we may save somebody's life. And that's why we're all nurses, right? So if you guys have any questions about my project, I know that was kind of short, but I didn't want to bore you a whole lot.
So
Peggy.
Oh, I'm sorry.
Sorry.
Is it still ongoing?
You know, we're still doing it.
Yes.
I'm not studying it anymore.
Well, I don't blame you.
Yeah.
You're through.
Yeah, and Rachel is the educator on the pediatric floor. She's pretty familiar with it. Plus, she used to work in the ICU, so she actually did that too. So she has a good understanding of it. Rachel, what do you think?
I think it's fantastic. I've read several things down while you're talking, and like Marguerite said, it started kind of with some friction on the floor as the ICU nurse having more experience in the critical side, going to the floor saying, who can I check on? They kind of felt at first like it was an attack on their skills. And then it started to become one of those things where it was just second nature because we kept up with it. And when we first saw, that first respiratory season after initiating it, when it first started catching people and catching those kids before something happened and saying, you're absolutely right, something's wrong with this child. I agree. I see that you have assessed this child exactly the way that I would have. I think something needs to be done. And so that collaboration and that teamwork, it really has just taken it to another level. And now in the off season when there's not a whole lot, they're sitting out there and like, hey, how's it going? How's the kid? How are the kids? How's everything? Okay, is there someone I need to take a look at? There's always that talk beforehand. It's really neat to see, and the collaboration between the two units now. It's like just a total breakdown of those barriers, and which is a lot of fun now. And
well said.
So anyway, it's been really, really good, and like Margaret also said, the ICU charge nurse can go in, or one of the experienced ICU nurses can go in and educate the family, the parents, and the nurse. But now it's kind of one of those things where it's like, no, you should be worried about this child. I see exactly what you're saying, and there's not a whole lot that I can help you with other than saying, let's try this or this. Have you thought about this? And then after those sorts of things, then saying, if we've tried all those things, I think they do need a higher level of care or whatever. So it's just a continuation, and like Marguerite said, it saves so many of those kids who ultimately would have ended up in respiratory arrest and being a rapid response and a code on the floor, because all of those children, a good portion of those children were intubated.
Yeah, they may have lost some brain. Yeah, they may have, because of the oxygen deprivation from the respiratory arrest. They may not have been functioning adults, but they all were adults. No, they're not adults yet. I'm an adult. But they were all fine. They were fine.
So as your interaction with your newer nurses, or maybe your less experienced nurses out on the floor, with your ongoing interaction with them, have you helped them validate some of the things that they possibly were seeing, and they going, I wasn't really sure, but I kind of thought of that. So has that really kind of help them with their skill sets and validate that and encourage them to be more, go ahead and be more vocal, proactive with what they're thinking and seeing?
Yes, okay. And to say, what, I am going to call that physician because now I have someone telling me that I'm right in what I see. Yeah. That something is wrong. I have that little voice. And, it just kind of helps those new nurses have that backbone to say, there's something wrong with this child and I'm not comfortable anymore. I've spoken with our ICU and they agree.
Yeah, and if, one thing I was able to do with this, though, is just look at the number of physician transfers after 10 p.m. So now we're working on having a hospitalist at night. So how many transfers are you going to have? It's not going to happen. So, this showed someone something, and they thought, well, yeah, that is a problem.
What was their buy-in? What was the physician buy-in?
They're not really involved in it.
Yeah.
And they pretty much respect the nurse's judgment, clinical judgment on the floor and in the ICU. And if they say, hey, we're worried about someone, they don't really want to come in. A lot of them are private pediatricians. They're not. 80% of our patients now are admitted under the hospitalist service, the pediatric hospitalist service. So there's a 20% group that is not. And we'll see that dwindling even more with the coverage at night by the hospitalist, because what pediatrician wants to come in from Wolford or wherever, So it's just a good deal. So that's going to enhance safety also. But every hospital can't have that, so.
And I think also along those lines is that whenever they, I don't know what I was going to say. It's lost me. Oh, when it's prevented the rapid response call for their patient.
Mm-hmm.
Okay.
When they don't have to have that on the chart. It could have been a proactive approach, which they know patient.
responsibility.
Mhm.
They do.
They don't like that because then they're like, well, why didn't you call me beforehand? Not a problem. Our Rover team was up here and we were concerned, and so this is what we did. And
So it's a win-win for both. Well, it's a win-win for both staff, physician, and the patient. So all the way around.
So do you have a pediatric rapid response team?
Mm-hmm. It's the same PICU charge nurse. No, we just revised the policy. It's the pediatric ICU charge nurse, the respiratory therapist, and the intensivist. We have 24/7 now PICU coverage. So now, I mean, it's all about safety now. So with that new model of care delivery, the 24/7 intensivist in-house, so he is supposed to respond also, he or she. Yes.
And they took your information and verified why they needed an intensivist?
No, actually that was just in keeping with standards of care for a level 1 PICU. Yeah.
I have another question. Do you think some of those transfers to the Rover nurse, were they early discharges out of the ICU?
Were they early discharges like the physician group or the rapid oh, you mean they left too early?
Right.
Yes, because during those winter months when you are in a bed crunch and you're full, yes, ma'am.
Okay.
That's for sure.
So at least somebody else had their eyes on them out there.
Yes.
And I will say on an implementation model that I'm speaking from the adult side of the same hospital. It was given to me to make this happen in the adult world. And so my challenge was, we have one rapid response team for several floors.
A huge hospital.
How do I mirror what the Children's Hospital did? So our innovative approach was, and it was just an aha idea one day, was why does our MICU have to be our only rapid response team at Covenant? We have a cardiac ICU, we have a surgical ICU. What better way to mirror the Children's Hospital than to split floors and assign these floors go to this rapid response team. So CCU is going to respond to these. We've got MICU responding to these, and surgical ICU can respond to these. And it allows them to have fewer floors to respond to, fewer patients, and more time to do the proactive rounding on the adult side. And we're piloting it right now on one of our units on the adult side. At first we had the rapid response team pager go off for both the CCU and the medical ICU at the same time. And so for a whole month they shadowed and went together. And then we kind of said, okay, as of now we're cutting you off. Medical ICU will no longer respond to just this one floor. And so they now have a month to 2 months worth of practice on just responding to rapid response teams, and we picked the floor that utilized them the most, so they're really getting the practice of it. So anyway, so we are attempting to model what Marguerite started in a different setting, which I'm sure, Sue, you're on the adult side. On the adult side is more of a challenge because it's not just a PICU and a PD floor. We're looking at a bigger environment. Bigger.
Yeah, it was a challenge, I think, for Duke Children's Hospital. They are huge, but they do that. They actually have implemented it quite well. It's not just that. Yeah, they are so good.
It's their leadership as well.
True.
Marguerite has, I hate to speak out of turn, but Marguerite has faced some challenges, I think, with leadership and has had to try to sell it pretty hard. And I think it speaks for nursing and fighting for what you believe in and saying that this is important. And if it works for children, it works for adults too. And so I think Marguerite has done a really good job pushing what she's done, and it's led to other innovations that we're working on now.
Yeah, the Children's Hospital has the family activation of rapid response, PICUs, all those are important. It all helps. But I have to say, really, when we took it to the physicians, they had a lot of questions. They didn't understand. So they didn't understand family activation and why that would be useful. And that's such a, astounding and wonderful thing. Why shouldn't a parent be able to call?
What is it?
That's where we call it Condition H. And we've educated our parents, when their child is brought to the hospital, if they feel like something's going on and no one's listening and they need someone, they can call this number, and the ICU charge nurse, she works hard, I'm telling you, she works very hard. Yeah, will come up to address their concerns, and it leads back to the whole Josie King story, you know, a child who died at Johns Hopkins.
Oh, okay, dehydration.
Correct, you know, because no one would listen to the mom, you know?
Yeah.
So we use that as the story, and that's the story we tell to our staff. You know, this is why we do this. But it was really difficult for physicians to understand that this was okay. Oh, they're going to be calling because they want the diaper changed, and you're just not going to be able to keep up with it. Never happened yet. So
one call.
One call.
And it was legitimate.
And it was legitimate. So that's a potential life saved. And the same thing with the pews. You know, they didn't understand that either. But hey, you know, here we are, these smart nurses that we all are, reading the literature and what's out there and saying, physician colleague, I need you to look at this. You know, and pediatricians are a little bit easier to sell, I think, than the adult docs. But
Probably not. I could
Yes.
yeah, they're just nice people, and they're not in it for, you know, they like kids, and you know,
There you go.
yeah.
Are you seeing a better documentation of vital signs with your PICU initiative? Because what a lot of the literature just says.
So that's Rachel. I don't know.
2% of the charts they review don't have incomplete vital signs, with respiratory rate being the number one. And even when it is recorded, we know that nurses aren't necessarily really counting that respiratory rate. I mean, it's just the evidence out there points to that. So are y'all seeing with all these initiatives actually better assessment of the patient, or more thorough
Better.
assessment?
I feel like the assessment ability of the nursing staff is better, yes, because we are asking them to really, I don't give the option. I mean, appropriate assessment is not an option.
Paint the picture.
And so, you know, it's just not. And so they don't have really, well, anyway, I just set that standard that this is the way it is, this is how I educate, and if you're not on board, there's other people that want to be. So, not that I'm that harsh, you know.
Is the documentation improving?
To be honest, I don't really know, and it's funny because I actually wrote while Marguerite was talking, pews, audit myself. And so I really need to, and that's something that's become my passion just in the last couple of months, is just saying, is this really being done? I'm asking this of the nursing staff, and I'm recognizing how important it is, but is it really being done?
Right.
And it is by probably half of our staff. And so I've now tried to come up with some things that will kind of force them to have to do it. And so, because I see the benefit, and when each nurse finally has that aha moment when it works for them, that's when it works. And I mean, that just happened last week.
That's great.
And so, so to be honest with you, I don't know about the vital signs. I would hope yes.
I don't know.
I would expect yes, but I don't know. So I'll have to get back with you on that.
Any other questions? You guys have been so sweet.
Well, did our Jenny and Rachel, I kind of asked them ahead to think a bit. Did you get to respond in the way that you thought? Did you have any other words in terms of response?
You were asking in case nobody else thought we could speak up.
Oh, no. Did I answer your questions?
No, I really want to thank you for the work you've done and what it's led to. You know, just for saving a life, any life is worth.
But it could be our grandkids, you know.
Or your great-grand?
Yeah.
I think it builds trust. You know, we trust whenever something now in the children's hospital, we see that when Marguerite comes with this grand idea and these grandiose thoughts, that it's not crazy.
Well, they
Show
do, at
us
the
the
beginning you
reason.
do think it's crazy.
Yes, of course. We all think she's so crazy at first.
It soaks in.
But you trust that now it's really something, and I think, you know, the physicians start to feel that way and everything like that, that we can really trust each other to not just have another paper. You know.
And it's evidence-based.
Yeah.
And I think the culture she's building in the children's hospital of evidence-based practice is key. Because what better culture could we have in the care of our patients and in our colleagues that we work with and the physicians is that culture of evidence-based practice, let's do it, there's no option. Like you said, this is what's best. Why wouldn't we?
Yeah, and like family activation of rapid response, old news. That's old. Everyone should be doing that. It's old news. Some of this is old stuff. So we're here to bridge that gap and make it go a little faster.
I do want to say one more thing that I just thought of.
Okay.
Sorry.
Please edit my faces that I'm
One of
making.
the things that has turned out pretty neat that I think with the Rover is that our staff nurses now, not just our charge nurse, but our staff nurses, if they're concerned, they'll call the Rover and ask them to Rover early. Hey, I haven't seen y'all
really
up here
good,
yet.
really good.
Do you mind, are you able to come right now? Because I have a question about a child that I'm taking care of or whatever.
Oh, that's wonderful. That's wonderful.
I would like to capture that in the research we're doing. That
I would like to
trust
capture that
building or
too.
that somehow the relationship, if there's a way to capture that. Just that is
That's huge.
It's like the bonus.
It is. It is.
Safety. We know there's safety in open communication, so it's actually a safety culture. It's a culture of safety built.
Thanks, Rachel.
That's awesome. Thank you all. Marguerite, we commend you for the work you've done.
Oh, thanks.
So proud of you. Thank you for sharing that with us today. And appreciate everybody coming because every single one of us is a vehicle for evidence-based practice. And it's a wonderful time to be a nurse. And I visited with a donor in Albuquerque a couple weeks ago. She is 84. She said, "Oh, Joanna, if I were just a little younger, I'd be coming back to school." And I said, "You know, it's a great time to come back to school because we are changing healthcare. Nurses are changing healthcare, and we are living it. We are living it, and there's more to come. And these small things that we're doing right now are shaping the future. We are shaping the future by what we're doing. And this is a perfect example of it, and you are a part of that as you arm yourself with the skills to actually carry out research and evidence-based practice in the workplace. It's ordinary people like us that make this difference. So thank you for your commitment to this, Marguerite. Thank you for your commitment to being here. And, for those that can't stay.